Yes, I begin to thank the King Baudouin Foundation, Julie Renson Fund, and Queen Fabiola Fund for the opportunity that give us to implement new research on transition, but also clinical new offer for the patients, and also to permit us to work together also with our Flemish team. We meet together, we don't know before, and it's a nice opportunity to do that. So thanks a lot for the next 4 years of the chair in transition. So, how does it work? Oh, yes. So we propose our project for the chair of transition. It's a psychiatry in transition, in a word on transition. Actually, and the introduction was quite in the same way of the idea of transition and of the word, actually, because there is a lot of change for the youth people, and there is a lot of need that are not encountered at that time, and we will have a look on that on the next few years. Okay. I want also thank all my collaborative team. I'm not alone to propose the chair. I have the help of Marie Delay, which is head of the Child and Adolescent Department in the Erasmus Hospital, Charles Cornrey, who is an adult psychiatrist, head of the psychiatric department in Hôpital Bruckmann, and Hélène Nicolis, which is an outpatient psychiatrist, child and adolescent psychiatrist at Centre de Santé Mentale de l'ULB. And I also present you the 3 young students, PhD students in child and adolescent mental health and also adult mental health. So it's a collaborative and, I hope, cohesive team. Dr. Simone Marchini, Dr. Johanna Reis, and Dr. Anthony Deleu. They are all working with me to present the project now. So when we propose that, we know that there are specific needs, and it was present just before, that are not actually encountered between CAMS and HAMS. And there is a lot of specific needs at the age of adolescent. You have said that there is a median age of onset of psychiatric symptoms were around 14, so it's very earlier, and usually it's not repaired at that time. There is also early or prodromal symptoms that are not specific and more fluctuating than in adult patients. There are also adolescent-specific risks. You have spoke about that, and all the studies have found that the coverage of psychiatric level of care is the lowest between 16 and 24 years. And there is also difficult access for that specific population because of financial, but also stigmatization reasons, and also because of specific troubles that are usually found in adolescents, such like ADHD or eating problems or personality disorders, or sometimes also addictions. There are also particularities of that age of the life because of physical and pubertal change, emotional related to particular neurodevelopmental aspects of the brain modification at that age. I will continue on that. And we know actually that the brain will be more adult around 24. There are also psychosocial factors and life events that are difficult at that age. Gender identity, schooling, education, beginning of words, integration in the peer groups, romantic and sexual relationship, family mutations also, modification of authority, migration, impact of new technologies, and so on. And there is a lot of challenge at that age group. There is also a great difficulties for young people who are suffering from neurodevelopmental disorders such as autism, ADHD, and also sometimes learning disabilities and so on. And when they are passing the transition period, sometimes it's difficult for them to find some help in the adult systems. There is also a great risk of interruption of care related to poor prognosis, as if people fall in the wall, as it was published before, they increase comorbidity. And it's also a challenge to reduce comorbidity with helping this young at that age. So we need to increase collaboration and also to plan movements from camps to hams. That's the same as I was your slides also on the particular increase of psychopathologic diagnosis at the age of adolescence. It's mainly about the modification of the brain and the reorganization of the brain at that time. But perhaps Mario Dilkrebs will speak about that in the end of the morning. But you see also the same beginning of age. These are the NIMH studies on evaluation of frontal cortex maturation from childhood to adulthood. And that's kind of research that have proved the end of maturation around 23, 24 age old. Oh, excuse me. What is also important at the age of adolescence is the imbalance between emotional brain and rational brain. At that time, there is hypoactivity of frontocortical regions which are immature, and this frontal cortex is implicated in executive function, planification, control of behavior, and it's immature at the time of adolescence. At the opposite, the emotional brain is much more hyperactivated in the amygdalian regions. And it's implicated in emotions, stress, and conditioning, but also that's kind of difference of functioning in the brain explain a part of the risk that adolescents use to take at that age. And there is also very interesting and important because that life events are toxic, such like drugs or alcohol, stress, and so on, have a different impact on that kind of brain that at the age of adult. So that's why the period of adolescence is a fragile period to begin psychopathology. Not only, but part of. So, excuse me. So, when the Fondation Roi Baudouin proposed the chair, they have 4 objectives. Research project, new research project on that age group, valorization and utilization to share knowledge activities, also education in academic insights, and also a social impact with communication. So it's a hard work for the 4 years to change the mentalities and to change the model of health for that age group. I will begin with the research project, our research project that I will present now. As I said, it's a large collaborative and cohesive CAMS and HAMS project, and with the support of the foundation and of the critics and the jury, we propose a transversal and transdiagnostic methodology. So we propose a dimensional approach for our research project. The objectives is to identify clinical dimensional characteristics that contribute to the development of psychopathology during transition period. And we were supported and influenced by the research domain of criteria, the RDoc project of the NIMH, which began in 2011. And actually, there is much more research on that kind of methodology, but we don't take all the methodology, I will explain you, but part of the methodology is supported by a dimensional approach. We will explore continuity, resilience, or discontinuity during transitional period that request attention to care. And we will develop a non-stigmatization, we hope, to develop a non-stigmatization approach in order to reduce rejection of the youth in psychopathological suffering and increase their social inclusion. It's also, excuse me, it's strange. That's why we call transition psyche in a word of transition, because actually it's also an interesting change of paradigm for research and also the comprehension of psychopathology. In adult and child and adolescent psychiatry, there are significant empirical evidence suggesting that only a single dimension can measure the liability to have disorders, mental disorders, to explain comorbidity among various disorders, and also the persistence of disorders over time. Perhaps it's simple, but it's interesting to question all the models, and mainly the categorical models. It's the article of Caspi in 2018. When you enter in that kind of mind, they propose two primary dimensions, an internalizing one and an externalizing one. We know that when we are child and adolescent psychiatry, because we have since a lot of time evaluation of externalization and internalization type of disorders. The first one is the liability to experience mood and anxiety disorders, and the other one is to the liability to experience hyperactivity, impulsive comportment, delinquence, and also addictive disorders. Longitudinal research showed that poor childhood self-control, reflecting emotional dysregulation and executive deficits, cut across all disorder liabilities. So that's what we call early developmental predictors, and we will explore that during the research. And they also speak about a third dimension, which is the psychotic one, the thought disorder specific of the patient who will develop a psychosis later. Most mental disorders now in the RDoc domain are now considered mainly qualitatively different from normal people and or in a continuum. Perhaps the best example is the autism spectrum disorders, because it's so large actually that the prevalence increased, but people who are some characteristic are mainly different than people who have a very hard problem of autism. So this kind of reflection about spectrum is very interesting. And when you are considering dimension and not category, you will introduce that evaluation of different dimension for everybody, you and me, and also the patients. That's the RDoC framework with 4 dimensions. The domains are negative valence, is the fears and the security, positive valence, cognitive systems, social process, and arousal modulatory systems with quality of arousal. And there are different kind of research. We will focus on self-reports and behavior in our research, but perhaps we can also add some neurophysiological evaluation. We will think about that in additional research. And all these domains explain, perhaps, they hope so, circuits between behavioral dimension and neural systems. There are also genetics research that are done on that kind of model. The principle is to develop a framework to study the psychopathology based on dimension of observable behavior and neurobiological measures. To identify, they hope, actually, to identify fundamental components that may span multiple disorders. And you say that it's not name of illness, but mainly function or dimension. To determine the full range of variation from normal to abnormal, and also to integrate different components from environmental behavior, genetics, and experiential components. So I will now present what we will do, but we will not do all that thing. We focused on a group of patients. The recruitment was a 6 group of 50 youths at the age of 17, which is the first time of the study, and we propose to reevaluate them 2 years later, and we hope 4 years later. But you know, longitudinal studies are quite difficult, but it's our hope, actually. The 6 groups are patients with neurodevelopmental disorder during childhood and adolescence, such like autism, ADHD, or early signs of psychosis. Inpatient with acute psychiatric disorders, with inpatients at the age of adolescence. Outpatient under stress, psychological stress, in outpatient consultation. Outpatient with specific addictive disorders, not only drugs, but also tablets and games, alcohols, and so on. We also propose a compare group of youth in aide à la jeunesse, service résidentiel pour jeunes. It's the Flemish part, it's, you know, not depending of psychiatry. And it's not the same way in the south and in the north, but it's the same patients. And also a control group of young people at 17 years old. At the beginning of the study, we will do a general database with sociodemographic profiles of the patient, detailed developmental and medical history, because also of perinatal events, quality of life, incident of life events, the different difficulty, neglected, and all things like that, family functioning, interpersonal relationship, and social adaptation at the beginning of the study. We use the milestone instrument to evaluate at the first time the transition readiness and appropriate measure, to have a beginning of the measure. And we also use the ONOSCA, which is a care need assessment at the beginning. The different scales that we will use for the different dimensional aspects is first the general psychopathology scale, internalization and externalization symptoms, the Aschenbach, with the U self-report, impulsivity, compulsivity, depressivity, suicidality, emotional regulation axis, and also cognitive functioning, because it's very important. We will use a brief IQ, and we will evaluate the executive function and also cognitive insight, but because it's pretty interesting to the patient who will need transition. At 2 years before and hope 4 years before, we will reevaluate the subject with a light model, because everybody knows that longitudinal studies are very hard, and if you use a too hard methodology at the second times, it will be more difficult to have the data. So we use a semi-structured interview with psychiatric or not, psychiatric intervention or not, a patient who will need follow-up, who have past or present psychotropic treatment, and also patients who have used emergency care and hospitalization. We will check the quality of life, and we will use the milestone instrument to the transition-related outcome measures. And then after, we will also evaluate the care need assessment as at the time of the beginning. And we had a therapeutic alliance questionnaire. So that's a hard project, but we hope with the help of the PhD student that we will encounter all these things to do. One of the second points for the chair is sharing knowledge activities. So, as we have to provide new perspective in the management of gradual transition, and also we hope to propose some evidence-based approach and new intervention models, it's need to improve change in the clinical practice. Because usually, there is only transmission, so you transfer your patient from child adolescent psychiatrist to adult psychiatric without transition. It doesn't work. That's the patient who are falling in the hole. So we have to deliberate a planned movement from child to adult psychiatry, such like pediatrists do for chronic pediatric disease. Diabetes and also nephrology and so on. They have model of transition in pediatrics, but there are few. There are in the world, mainly in Netherlands, and now begins also in France, but last year, there are only 11 studies on transition in psyche around the world, so there are few models about that. So we have to work on that. And it's not simply to stop care and to begin in a new department. The transition must be gradual, prepared by meetings between professionals and also the parents, the patient, and also the parents. We don't need to forget the parents, with a movement of parallel work and a systematization of that transfer for patients who need transition. Not all patients who have asking help at the time of adolescence need transition to adult psychiatry, but patients who need that, we have to prepare that and to work both to do that. And it will, we hope, reduce the stigmatization in the general population, as if we don't work on that transition, people will increase comorbidity, mainly addictive problems, but also suicidality, and also desocialization. So I coordinate the project. I have all my collaborative research team, but we have also collaborative partners, and we made the first meeting in December with a lot of partners from the French part of Belgium, academic partners, clinical organization, mental health partners, and also intersectorial partners. It's very important, and it's on the model of the networks of the new politics. We don't have also not to forget the families and the user, the target population, the youth and the family association, and also the communication. That's the model of our proposition of chair, and the youth and families are on the center of the model. And this afternoon we will have exchange with a patient and also with families who have lived the transition. These are all the mental health partners. We will have a hard work also to motivate them to work with us in and out mental health care partners network, in adult psychiatry, in child and adolescent psychiatry, in youth welfare service, youth court, social defense units, general delegates of children's rights, cultural sectors and arts. So we have to invite to the reflection a lot of partners to sensibilize them to the importance of transition. So there is also academic insights at different levels of the French community in the Wallonie-Bruxelles Federation, high school and universities, and I also want to thank my colleagues of Université Catholique de Louvain, who don't have received the chair, but who want to work with us to the project. So it's very thank to you, and mainly Nicolas Zdanovic. In collaboration, and also Philippe de Timary, they are immediately in contact to work together on that project. Also trainees in medicine, faculty, psychology faculties, nursing, social assistant, and educative schools. Also the general practitioner, pediatrician, and so on via the scientific society. And I have also good news as the King wants to make a symposium here in the academy next year on child and adolescent mental health. She said that it's a very important point, so there is also a meeting on that, and an important way to communicate about that. So I want also to propose for the French part of Belgium, but the Flemish can also join us on that. Save the date. It's a French colloque on transition à la faculté de médecine de l'ULB in May 15. Next and last, the social impact. We have to communicate about that, so there is Maud, which is the communication girl for my hospital. The communication of the university is also supported us today, and for the chair. And we have done a communiqué press for that kickoff today. Thanks a lot for you.